This session is inspired by the Northern Lights, something that's on the top of my bucket list to see, I haven't seen yet. And we're going to provide a discussion of premium options and premium treatments for natural vision. We have an absolutely wonderful panel here today who are going to be presenting some of Bausch & Lomb's newest innovations in this area, where we're going to focus on premium IOLs, the Elios treatment for glaucoma, and also refractive procedures with Teneo. So a lot of exciting things, so we want to get right to it. First, we have Professor Sympo Teneri. He is the director of the Center for Refractive Surgery in Münster, Germany, and one of the owners of the eye department at St. Francis Hospital in Münster, Germany, as well as lecturing and conducting research in Bochum, Germany. I had to work hard to try to say that word. He has a wealth of experience with Bausch & Lomb's excimer laser platforms, including the current Teneo platform, and he is going to share his experience with the latest procedures, the customized corneal Octavius and TransEpi PRK. So without further ado, he's going to share illumination on the latest Teneo M2 refractive surgery procedures, Octavius and TransEpi PRK.
Thank you for the nice introduction. I hope you find the food nice. You came for the food, maybe you can stay for the talks. Actually, I wanted to talk also about hyperopic LASIK, but I was not allowed to. So obviously, Bausch & Lomb has too many innovations, and we have to go forward with only two laser innovations. So let's start with my financial interests. Obviously, I get paid for this talk, but I am a Bausch & Lomb user for more than 20 years with different excimer models, and we have had the prototype of the Teneo more than 10 years ago. So the latest model, the 370 Model 2, has ProScan, aspheric ablation, wavefront-based ablation, presbyopic ablation, obviously PTK for therapeutical ablations, and TransEpi PRK as a new feature, and Octavius as the latest topography or tomography-guided ablation feature. And that's what I will be focusing on. So we lacked customized corneal treatment in the last few years, and I'm super excited to have this option now for a year or so. So Octavius is a fancy name for topography or tomography-guided corneal treatment. You can use individual corneal data from the ACE, from Bausch & Lomb, or the Anterion from Heidelberg Engineering, or the Sirius Plus from CSO. These machines will then drive the laser, and then you can decide whether you want only corneal anterior topography, as you can see here, or you want total corneal topography and tomography. And you can adjust the treatment intensity from 1 to 100%. So this is the theory. Let's start with a very first case, femtoLASIK with a superior steepening in both eyes, very symmetric corneal astigmatism. This is the opposite of keratoconus. So because this is a symmetric situation, we decided to go ahead and do the ProScan LASIK in the right eye and the Octavius LASIK in the second eye. And here you can see the small differences. This is the Octavius eye, small concave structure here, more convex than over here. So that's the ablation pattern, and that's the result. With the ProScan, we have this result. We have a superior steepening to start with, and superior steepening after ablation. However, with the Octavius, we have a superior steepening, but no superior steepening after ablation, because we have a higher ablation in this area compared to that area. And the right eye serves as control. So Octavius is doing what it's supposed to do. And with this experience, we got more courageous and started to treat this eye, which has a scar after pterygium surgery. So this is the area where the pterygium was removed. This is the fellow eye. Both eyes refract to more than 20/20. And we entered the Octavius in that post pterygium surgery eye, and we got this 7.5 diopter gradient. So this is the difference map, and this is how the cornea looks almost perfectly topographically wise after ablation. This is a TransEpi PRK combined with cross-linking for keratoconus. As you can see here, we have a gradient of 14 diopters between the blue area here and the inferior steepening here. So we combined TransEpi PRK. This is the manifest refraction, of course not refracting to 20/20, but we did not treat the sphere at all. We only treated the cylinder, and this is what we got. We got a difference of 10 diopters flattening centrally here. And it's not perfect, but it's much better than what we had before. TransEpi PRK in a normal cornea. Can you do that in a normal cornea? Well, you can. I don't see a need for it because we have an excellent ProScan ablation, but you can. And the older topographical ablations were plagued with poor predictability. So you regularized the cornea, but you worsened the refraction. In this case, very low refraction. We targeted plus 0.5 because of the young age of this patient. And this is exactly where we ended up with. So uncorrected 1.6 and with best refraction also 1.6. So very predictable refraction. So we are just exploring all the options that topography-guided ablations with the Teneo and the diagnostic tools are offering us. So I think there is more to be expected in the near future. Let's switch gears. Let's go to TransEpi PRK. This is a retrospective consecutive case series, routine patients. And this is our method. We cool the eye before ablating the epithelium and the stroma in one step. As you can see here, this is real time. And then we cool again. This is the stromal ablation now. We cool again because we have this paper on the effect of epithelial ablation, which increases the temperature on the cornea. So in order to avoid pain and inflammatory reaction, this is our protocol with a lot of cooling. And it makes sense. We have 199 eyes at 3 months. This is the safety index, 1.1, and 1.0 is the efficacy index. Results are excellent. 99% are within one line of best corrected visual acuity after surgery, but uncorrected. Predictability also very good. And astigmatic correction is also excellent, although the epithelial thickness in the periphery is not yet taken into account. So this can also become better in the near future. But although we have a uniform epithelial thickness entered into the laser, these results are outstanding. So in conclusion, we have, with the TransEpi PRK treatment for myopic and myopic astigmatic eyes, we have outstanding safety, effectiveness, and predictability. Thank you so much for your kind attention.
Thank you so much for that. I had a couple questions, and then we will save audience questions for a little question and answer session at the end. So if you have a question, jot it down so that we can discuss that with the panel. So tell me about pain perception for the patient with the TransEpi PRK.
Okay. This is exciting because we are just in the process of finalizing a paper on that. So TransEpi and pain is, well, 15 years ago, my patients came in like that on the next day. They couldn't open their eyes, they had swollen eyes, they had inflamed eyes, and vision was poor because they couldn't open their eyes, basically. Nowadays, they don't experience pain on day one. They come in like that, and in the waiting room, you cannot tell apart the LASIK patient from the TransEpi PRK patient. With cooling, with non-steroidal drops, just one drop after surgery, they have almost no pain.
Yeah, that's remarkable. I did PRK on my son and my daughter, and they definitely were not happy the next day. So having a patient that's that comfortable is amazing. So tell me, if you did TransEpi PRK with or without cooling, what would be the difference in pain perception?
Oh, there's a huge difference. So I would advise to do the cooling. Ice-cooled solution, like 30 cc, before and after surgery, after ablation. And that avoids to increase the corneal temperature and avoids a lot of inflammation.
And how much variability is there for patients in that, though?
They don't
everybody
like
uniformly, as far as the cooling, is it effective for everybody, or are there some?
Yes, it is effective, but the patients don't like the cooling part.
Oh, they don't.
So we warn them in advance, and they say the cooling is the worst thing about it, about the whole surgery, but it's really worth it.
And you would say, but tomorrow would be the worst thing if we didn't do the cooling.
Yes.
Yeah.
Yes.
Thank you so much.
Thank
that was
you.
really great. So yes. And now we are going to welcome Professor Christina Ledl from Austria, and she is a senior cataract surgeon and researcher at the Department of Ophthalmology in Vienna. Her research focuses on intraocular lenses, innovative lens technologies like multifocals and EDOF lenses and torics, as well as improving outcomes through precise biometry and laser-assisted surgery. She will be presenting and sharing her experience with the Bausch & Lomb new EnVista Aspire IOL. So we're very excited to have her present on elevating the everyday with the EnVista Aspire IOL.
Thank you, Kathleen. These are my financial disclosures. So can you guess what this young gentleman wants? I'm pretty sure you can imagine. Many cataract patients today want more than just clear distance visual acuity. They want reduced dependency on glasses for everyday tasks, but without halos and glares. Presbyope correcting IOLs have their restrictions and contraindications. It is not the best solution for monocular patients who had previous surgery in one eye maybe, or patients who need their perfect contrast sensitivity or are driving at night due to their jobs. Patients with irregular cornea or previous LASIK or PRK, patients with significant dry eye disease or pathologies of the macular retina or glaucoma with visual field defects, abnormal pupil, and so forth. So what can we offer these patients? Maybe monofocal plus lenses are a good solution for them. But what does the plus stand for? The sharp focus in monofocal IOLs usually is in a single distance only. With monofocal plus IOLs, we can get a sharp distance and improved intermediate vision. Intermediate vision is getting more and more important for the patients because we have a lot of work on desktop computers, work in arm length, cooking, watching their instruments in their cars. And with monofocal IOLs, it's limited. You usually require glasses for this distance. Monofocal plus IOLs can significantly improve intermediate vision and often possible without glasses. The near vision in both lenses, you usually require glasses. With monofocal plus IOL, sometimes for some patients it's possible without glasses, and it's significant, but glasses are often still needed. Contrast sensitivity is high in both groups. You don't have photic phenomena in monofocal and monofocal plus IOLs. Patient adaptation is very good, and refractive predictability is simple and precise also with the monofocal plus IOLs. So I would like to introduce you to the EnVista Aspire, a new monofocal plus IOL. The platform is the well-known EnVista platform, a hydrophobic acrylic IOL with an overall diameter of 12.5 millimeter length and a 6 millimeter optic. And the lens uses in a 1.5 millimeter central zone higher order aspheric coefficients to make a broader depth of focus. It uses a so-called 3C technology. The optics are designed to harmonize the power profile between the periphery and the center. The power profile has a really gentle, gradual distribution of light energy from the center to periphery and is designed to minimize halo glare, so the dysphotopsias. This is the power distribution profile of the lens, not its actual shape. In its optimized central zone, it provides a power increase of 1.2 diopters, so this would be the darkest ring here in this illustration. And before a lens ever goes into a patient's eye, it first has to prove itself on, let's say, dry lens or in the lab on the optical bench. And here is a comparison of the EnVista Aspire here in blue compared to the Tecnis eye-hands in gray. And you can see clearly that in optical bench testing, the EnVista Aspire demonstrated a similar depth of focus compared to the Tecnis eye-hands. After passing the optical bench, the lens is allowed to perform on a bigger stage on a clinical trial. An ambidextrous multicenter single-arm study was performed at 7 sites in the United States. 82 subjects underwent bilateral cataract surgery with implantation of the EnVista Aspire IOL. The follow-up was between 60 and 270 days after second eye surgery, and main outcome measures were photopic monocular and binocular distance-corrected visual acuity, distance-corrected intermediate visual acuity at 666 centimeters, manifest refraction, binocular defocus curves, and patient-reported outcomes. And here are the results. So 89%, as the graph shows here, of patients had a binocular best-corrected distance visual acuity of 20/20 or better. The mean distance visual acuity was minus 0.05 logMAR, and 65.9% of the patients had a distance-corrected intermediate visual acuity at 20/32 or better, and the mean was 0.21 logMAR. So it was quite a good functional intermediate vision for everyday tasks. The American National Institute says that the depth of field is defined as the dioptic power from the best peak, which would be here, of vision up to the defocus point, for which the visual acuity is 0.2 logMAR. So this is the depth of field of this lens, and it shows a continuous depth of field of about 1.25 diopters for a visual acuity of 0.2 logMAR or better. In this study, also a questionnaire was performed, and the questions comprise questions about the frequency and bother of ocular symptoms, inquiries about general vision, and the necessity of corrective eyewear. And here you see that over 92% of subjects experienced little to no discomfort from visual disturbances during the day. 90% of subjects were overall satisfied with their vision, and 83% of subjects were happy with their intermediate vision without correction. So to conclude, in this clinical trial, with 82 persons with the EnVista Aspire demonstrated a good functional intermediate vision without compromising distance vision, a continuous depth of focus of 1.25 diopters, and minimal visual disturbances and high overall patient satisfaction. So I've had already the pleasure of implanting the EnVista Aspire myself, and I'd like to share my first impressions quasi straight from the operating room. These data are based on our first 5 patients. To be honest, it's a very small cohort, but even the largest studies have to start with patient number 1. And we found an excellent best-corrected distance visual acuity of minus 0.02 logMAR, and also very good distance-corrected intermediate visual acuities here at 80 centimeters and here at 66 centimeters. So it's really good comparable to the US trial. And these results are, visual acuity results are assessed monocularly. Our first patient were also very happy and satisfied with the lenses in their everyday life. We assessed this with a VV7 questionnaire, so they don't have difficulties at driving at night, watching television, and patient satisfaction was overall very good. And I'm always curious about how new lenses work, so I put one patient with an EnVista Aspire IOL in front of the wavefront analyzer, and here you can see clearly how the spherical aberrations here in the 1.5 millimeter zone are modulated, and we keep on implanting diligently the EnVista Aspire. So in a few weeks or month, maybe I can tell you more data. So to conclude, the EnVista Aspire is a monofocal plus lens that offers an excellent distance vision with functional intermediate vision. We have no typical photopic side effects like multifocal designs. It shows stable refractive outcomes, has a simple biometry and IOL calculation, and with the lower neuroadaptive demands, it also has for the patients a shorter adaptation period. So in my opinion, it's ideal for a large population of cataract patients seeking safety and everyday practicality. Thank you.
Thank you so much. And we're always so grateful for people to show their early real-world experience, because sometimes, you know, we get data that comes out of trials and then we try something in our practice and it doesn't follow the same pattern. So it's really reassuring to see that your first 5 patients were what we would expect from the trial data. So, but now that you've had this for a while and you're working it into your array of things that you offer patients, who do you think it is that are best candidates for monofocal plus lenses?
I think it's good for patients who want a precise distance vision, but also want a functional intermediate vision in their daily life, so that they can get spectacle independency for most of the day. So you have to tell them they have to have reading glasses with dim light or small print sizes, but usually for like working on a computer, cooking, walking around, it's very suitable for these patients.
Yeah, so we know that there's always a compromise, right, with whatever strategy we have. So these are the patients who say, I don't want to compromise anything at distance, but give me more if you can.
Yeah.
So is there anybody who's not a candidate for a monofocal plus lens?
I would be very careful when they have ocular comorbidities that maybe is higher corneal aberrations, so high RMS or spherical aberrations. I would also, because of the central part of this lens, I would also be very careful when there's a decentration and tilt previous to surgery, so after trauma, or maybe with a severe pseudoexfoliation syndrome. Yeah, these things I would be very careful about that.
Yeah, and the really nice thing is it's built on the EnVista platform, which we know has such great long-term stability, and it has power from edge to edge, so many great factors building on that platform as well. But thank you so much for your discussion. Hopefully we'll have some more time at the end for more questions.
Thank you.
So I'd like to invite Dr. Francesco Corones from Italy. Nobody needs an introduction to him. However, he is the chairman and medical director of Elios Vision in Milan. Well, let's do that introduction again. And he's the president-elect of the European Executive Committee and an entrepreneur. He is also speaking about Bausch & Lomb's new premium IOL, the LuxLife. So thank you so much for joining us today.
Thank you, Katie, for this wonderful introduction, and thank you to Bausch & Lomb to allow me to present this very interesting lens and for having given me the possibility to implant the first commercial one back in June. So we are talking about presbyopic correction with a new strategy, with a new lens. I have some financial disclosures to make. You can read here, and this talk was sponsored by Bausch & Lomb. First question that comes to my mind when I started planning my presentation was why? Meaning, do we really need one more full range of focus or vision, presbyopic correcting IOL, given that we have plenty of them? And these plenty of them give us multiple options. The technologies basically reduced a lot of issues that were raised in the past by the earlier technologies. The broad range of vision that these lenses provide would not really justify one more lens, and patients are quite satisfied with the current generation of full range of focus IOLs. So was there really a need, an unmet need for these technologies? Where, yes, there is, and there was. First of all, some trade-offs are still unacceptable, like some patients suffer from night dysphotopsia. New technologies may also broaden the spectrum of patients that can benefit from these technologies. You heard earlier that in some cases, patients are still contraindicated. So the fact of using a more gentle technology may allow for more patients to take benefits and advantages of this technology. And also, we are seeing some sort of a slow surgeon acceptance to this kind of IOLs because of the compromises that Kate was mentioning earlier. I want to show you a graph presenting my own IOL choices over the past 10 years. And you see that what changed in a dramatical way was in between 2023 and 24, where refractive PC IOLs, other brands, other technologies, played a huge role in bringing more satisfaction to my patients, at least in my practice. So I think that the idea of going refractive was a brilliant idea from Bausch & Lomb as to provide a lens intended to provide a full range of focus, but with less or low of the photopic phenomena and discomfort that diffractive technologies do provide. And I want to go really into details on the physics of this IOL. I mean, engineers are much better than clinicians on that. Just want to point out that everything happens in the very central area, let's say in the central 2.2 millimeters, where patented technologies are inducing spherical aberration, both on the positive and the negative sign, as to elongate the focus. So this is not real trifocal IOL. This is more like an EDOF IOL able to provide a longer range of focus than what the current generation of EDOF lenses do. And as you can see here, this is done not through a geometry involving diffractive patterns, but just curvature changes. So this is a purely refractive lens. Here are some of the features of the lenses, of these lenses. I'm just pointing out the new cartridge, which is extremely smooth and allows to use your push or screw mode to have the lens implanted, and the wide range of dioptric power, +5 to +32, with astigmatism starting from 0.75 diopters, which I think is critical to get the accuracy that you want to get also on the toric side. What about the optical bench testing? These are optical bench evaluations, and you see here that the focus curve of this lens, in this case the LuxLife is the blue one, really matches what the competing companies, or even does better, of what the competing companies are delivering nowadays. Again, another purpose of these lenses was the optical bench testing being more forgiving, both as regards decentration as well as regards tilting. And you see here, again, in blue, that the LuxLife proved to be more forgiving than competing technologies. And finally, the question related to quality of vision and night dysphotopsia, especially when pupil dilates. Another target on the optical bench for this lens was to provide a lower amount of high-order aberrations, toxic high-order aberrations, so inducing less of the dark night dysphotopsia that almost always discourages surgeons and patients from adopting this kind of lenses. I'm going to present you the, let's say, the 6 months clinical outcomes of a multi-center trial where the LuxLife was actually compared to the LuxGood, so to the monofocal lens. And you see here in the picture how smooth, how nice is what you see at the slit lamp after surgery. So the presence of this very gentle and smooth change in curvature is almost undetectable unless you go there and really try to find it. Here is the binocular photopic, the focus curve, testifies for this very wide range of focus that the lens is able to provide. I think that this slide speaks for the results that you can get in terms of spectacle independency when this is implanted bilaterally. And here is what you can get at all distances. Distance, intermediate, and near in these three graphs at 6 and 12 months. Again, these numbers that I'm not going to read, I'll leave them on the slide, testify for the efficacy of this lens in providing spectacle independence to our patients. Let's see what may be wrong or what we do not like in full range of focus IOLs. Contrast sensitivity. Here is what we see on the binocular photopic and mesopic contrast sensitivity, again, compared to a standard monofocal IOL. Is there a little bit of, compromise, or there's not free lunch, as Kathy would say? Yes, there is always a little bit of something that it is not as a monofocal IOL. But you see here that the compromise is neglectable. There is a little bit of contrast sensitivity reduction, but still within the normal range. And also, when testing it under mesopic contrast sensitivity, even more, the compromise is almost not there. So from that perspective, this lens looks extremely safe. What about the patients' generated outcomes or reports? Well, by the McAllinden questionnaire, 6 months after surgery, again, I'm not reading the entire slide, I'm just focusing on the very low complaints and very low perception of night vision problems. So this lens seems to provide what we want to have from a full range of focus IOL. Not just the full range, but also a better performance in terms of dysphotopsia when pupil dilates. Here is the surgery, the first one that I did. As I said, the cartridge and the new injector system are very nice. The lens is based on the platform of the Lux family, so you're familiar with it, you're familiar with it, but I want to focus your eyes on the difficulty in finding the central 2.2 millimeters pattern. You see that even by moving the lens under the light of the microscope, you will not even detect it. I'm just playing with the eye as to try to find it, and you see how difficult it is to find. What does it mean? It means that if it is so difficult to find it under the microscope, not only the patients will not find easily, but also when bringing the patients under sophisticated evaluation systems like a high resolution aberrometry, again, the CEO aberrometer that Christian was showing earlier, here is what the aberrometer starts with the measurement. And here is a traditional diffractive trifocal IOL. So you see different grade of shades, which is the principle this aberrometer works, but also defined steps, right? Steps are the diffractive rings. How does it result? Well, you see here, this waving effect, blue to red, gives the depth of focus, ranging from myopia to presbyopia over the same area. The total sum is neutral or near to neutral, and the let's say the range in between the blue and the red gives the extended focus, right? Look at the LuxLife. You will not see almost anything. You can see a little fold in the capsule, totally not related to the lens. But this is what you see. What is the aberrometer seeing? Almost nothing. Guess what? This patient does not complain about night vision problem. And I think it's easy to understand why. I don't think that you need more words to explain it. Is this lens sensitive to pupil size and pupil changes because of the fact that only the central part has this modification? Well, let's see. Here's the same evaluation under a 5 millimeters pupil size and a 2 millimeters pupil size. Unfortunately, you cannot really very well the numbers, but basically you do not have any changes in terms of refraction, and you do not have any changes in terms of aberrations. So whatever the pupil is, this lens provides the same outcomes. Just to conclude and to have some take-home messages as regards the LuxLife. The multi-center study showed to provide a very satisfactory level of uncorrected visual acuity at all distances. You have seen the defocus curve. The range is very wide. This is classified as a full range of focus continuous lens, so there are no peaks, there are no bumps, there are no spikes in terms of the defocus. The level of spectacle independence recorded was very high and very satisfactory to the patients, as well as this photopsia profile. So I think that this lens has a future, and I'm really looking forward to implanting more of them. Thank you.
Yeah, thank you so much for sharing that. I think it's very exciting to see all of the advances we have in trying to really meet the needs of patients in all different areas. And so with this different approach, and I think what impressed me a lot was the difference in the dysphotopsia profile that we saw compared to trifocals, which are getting better and better too. But is there an unmet need in presbyopia-correcting IOLs that this is going to fit into? And do you think, if that's so, that we are going to be able to expand the market in the number of patients who are able to utilize these strategies?
Well, what I'm expecting from a lens like this is to cannibalize a little bit the market of diffractive trifocal technologies because of the range of focus, but mostly because of the reduced photic phenomena. I think that's the key and that is basically the unmet need. But also, when you have a lens in the full range of focus lens range, reducing that low the contrast sensitivity, I think that may, results supported, bring us challenging a little bit more those cases where we do not feel familiar with when like implanting a trifocal, a diffractive pattern. I'm talking about the very early glaucoma cases. I'm talking about the minimal changes in the retinal pigment epithelium. Those cases where now we are a little bit concerned in giving up a little bit with contrast sensitivity. Well, with this lens, we will be a little bit less.
Yeah, I think that is exactly where I think it fits as well. And I think the nice thing is sometimes when we're trying to avoid some of those things, especially dysphotopsia profile, our default is to go to a need-off lens, right? But we're sacrificing near. And maybe we have something that allows us to preserve more near now for those patients.
Yep.
So thank you so much.
Thank you.
Yeah, I'm going to invite now Dr. Anna Miguel from France. She works at the Central University Hospital of Caen, France, as well as the hospital in Avranches, France, which I apologize for any poor pronunciation.
You nailed it.
And she's going to focus on glaucoma and advanced anterior segment surgery as she does, and also share with us her experience with Bausch & Lomb Elios excimer laser treatments for glaucoma.
Yes,
Thank you.
Thank you, Kathleen. And thank you all for being here to talk about glaucoma. So I learned so much, and I'm a little bit off topic here because, it's glaucoma. Who cares? We all do. So let's now start with a new treatment, very interesting, and I'm really excited to present. So this is the Mont Saint-Michel, where I live 20 minutes from there, and it has the northern lights. So I thought it was a little bit poetic. So this is my disclosure. And as we all know, glaucoma is very, very common. Particularly, a study with 500,000 participants has shown that 20% of all cataracts that we operate are in glaucoma or ocular hypertension patients. So about 6 million a year of patients that I believe we can be doing more for them than just operating cataract. So what I'll try to convince you is not to take the road of the missed opportunity and to help you tackle also the glaucoma at the same time of cataract. Another interesting study has shown that the IOP, there's an IOP spike of about 20% after a normal cataract, non-complicated one. Usually we don't detect it because we see patients at post-op week 1 and post-op month 1, and we don't see that spike. Particularly in glaucomatous patients, this spike can go up to 45%. So these patients are the patients that we don't want the pressure to rise. So these are the best opportunity to add a mixed surgery or a glaucoma surgery to this cataract. Also, we want to tame glaucoma while it's mild. This is the whole philosophy of interventional glaucoma. Glaucoma is a dragon, and if it's mild and cute, we can manage it, and if it's big and very advanced, we need to take further risks in the surgery to tame it. So tame glaucoma while it's mild. However, we're not going to do phacotrabeculectomy to every single patient, right? It has a very high risk of complications, some unpredictability. So we should do an optimized approach. If we do have an advanced glaucoma, we'll have to do a bigger surgery, riskier surgery, filtering surgery, for example. But moderate and mild glaucoma should have another approach. So the optimized approach should be with very little trauma, highly adaptable and reproducible, and ideally implant-free. And there's only one mix that is completely implant-free, and this is Elios. So Elios is a very safe laser procedure. It's a 308 nanometer xenon chloride excimer laser. So this is extremely precise and non-thermal. So there has been some studies that have shown in terms of electron microscopy and in terms of microscopy that there are no fibroblasts increased after 5 weeks after this procedure. It will enhance the outflow, the natural outflow into Schlemm's canal, and it has, as I told, a minimal inflammatory response. We need to prepare for surgery, so this would be the learning curve. It is a very short learning curve, but we do need to learn how to do a gonioscopy and how to do an intraoperative gonioscopy. Here I'm showing that you need to tilt the microscope and you need to tilt the patient's head about 35 to 45 degrees, microscope towards you, and patient head 45 degrees head against you. And there are some apps in which you can just with your phone see the inclination and that just to do a little line so that you know how far do you need to go. Same post-op meds as for cataract surgery. When I started, I checked up on patients very regularly. Now I see almost as a cataract surgery. The equipment is also quite easy. So this is the console. All you need to do is follow the instructions. I mean, the nurse needs to remove this plastic without contaminating. So we do need to do a small staff meeting, but really easy and straightforward. This was one of my fears when I was starting, but really no-brainer. As for the handpiece, you'll see this little diamond. You should put your index finger into it because the probe will have 25 degrees. This is to have the best apposition against Schlemm's canal, so you will push gently, so we'll touch but without really pushing against Schlemm's canal. And here I'm just demonstrating that if we do a supination maneuver, you will have much more liberty of movement, and this will enable you to treat a larger area. So a video as easy as it gets. This is a Elios with a regular cataract. I'm doing a combined surgery. You can see there's a dense cataract there waiting to be treated. I prefer to do it before cataract surgery because the eye is dense. I have a nice view. And as you can see, I'm starting from left to right. This is the nasal quadrant. I operate temporally. And you can see the little blebs that are forming, showing the laser effectiveness. And then I'm going to show you again. So basically, just going from left to right, nasal quadrant, you can do at least 90 degrees. I go up to 120 degrees or even more, because with that supination, you have more movement of, in your hand. This is real time, not edited, so just so that you see the learning curve is quite short, but you do need to do your best, of course. This I'm just injecting some OVD to demonstrate it, and in the OCT, intraoperative OCT, we can see this 210 micron tracheostomy is really small, really difficult to see. So another video showing exactly the same. So this is in pseudosfoliation glaucoma, in which I'm doing the Elios, so really fast and ideal to do with a cataract surgery. You can see the Elios microchannels with these fine images and a post-operative image of up to 3 years. And we do have published outcomes of 8 years of follow-up, which is really interesting, showing an important effectiveness with an IOP reduction of 29 to 43%, up to 82 patients medication-free at 1 year. There it is from Reason et al. So 8 years, a very interesting and long-term study, of course, with some follow-up losses. Modeno and Valadares that showed 82% of patients medication-free. So usually if you go to my office, let's say 10 years ago, you could see who were the glaucoma patients, right? These guys with the red eyes, they were the ones taking eye drops. And now you don't see that anymore. So patients are really, really happy, and they have a very high quality of life now. This study from Nguyen et al. Shows also in the panorama. So if you compare with other more invasive surgeries and with other MIGS, I would say it has the right balance. So you can do it in combination, standalone, primary or secondary open-angle glaucoma. And in conclusion, don't lose the opportunity. Glaucoma and cataract is important. If you have IOP spikes after doing cataract in a glaucoma patient, this will be dangerous and this will not be detected. So do no harm, primum non nocere. Glaucoma is irreversible, so we have to take one opportunity to take the glaucoma and control it while we can. And in interventional glaucoma, the sooner we act, the better. But we need to act effectively with evidence, implantless, and with the lowest risk possible. Thank you very much.
Thank you so much. And I do want to leave some time for our audience to have questions, but I'm curious, how many people in the audience do MIGS surgery or do angle-based surgery at all? So some, yeah. I would encourage you to try to do that. One of the things I found as an unexpected positive was I keep my operating microscope at an angle all the time, and I can sit back a little bit, and it's much better on my back and neck, actually. So it was an ergonomic decision for me. But tell me, who is a good candidate or who might not be a candidate for Elios?
Exactly, that's a very good question. So for Elios, so this is a MIGS, a safe MIGS, but ideal patient would be primary open-angle glaucoma or mild or moderate, in which the glaucoma has an IOP that is not above 30, for example. And one of the things that I didn't mention is that you need to have a clear communication with the patient and set the expectations right. I usually under-promise and over-deliver. I really, really like to do that. And we agree upon whether the patient wants to get off his eye drops or simply lower the IOP. I usually do not promise both. Even if I know that I will have both, I try not to promise because this is a question of probability. So I'll say I'll do this procedure because it has the highest probability of success of whatever we agreed upon, and I'll write it in the file so that later on I can know exactly what the patient wants.
And that's terrific. Do you do anything different? You already said that the post-op management and your drops are pretty much the same as what you would normally do for your cataracts. Do you follow these patients any differently than your normal cataract surgery patients in the early post-op period?
I do. All my glaucoma patients are followed differently. I'm extremely attentive to those, even if I use a little bit of telemedicine now that we have, so I don't see them directly if they are okay, but I find a way so that they have an IOP at, for example, 6 months, just to make sure they are okay. Yeah.
Yeah, that's great. I want to leave time for our audience. We do have some microphones that you can ask a question. Does anybody have a question that they would like to ask our really very experienced and wonderful panel? Yes? You're talking about with the Elios procedure then? Do you see any side effects or bleeding or?
So intraoperative, there are many tricks. I'm lucky to have almost all the MIGs there are and have an experience with all of them. A general rule of thumb is intraoperatively, you have to have a reverse Trendelenburg and put your head a little bit over the, higher than the heart so that you have less reflux bleeding. And if you have intraoperative bleeding, you inject OVD from left to right and not on the middle, because otherwise you'll have lots of blood all over the place. Post-operatively, so intraoperatively, immediately after surgery, I'll leave the eye tense, at 30 millimeters of mercury at least. And interestingly, I would say my rate of IFEMA post-Elios is 0.
Yeah, and one of the things is just being comfortable with that view during surgery, that if you're able to keep the anterior chamber nice and pressurized, it's much less likely you'll have some reflux. And with some of the more modern or newer types of gonioprisms, there's no real pressure on the cornea, or you can leave them their hands free, which helps a little bit in maintaining the anterior chamber and alleviates some of that. But I always think when we see a little reflux, I always think, well, you know, I know it's in the right space, which is a good thing too. Other questions on any of our topics? There's so many exciting things we can talk about. Yes, so the difference, the question is there a difference between the EnVista and the LuxLife platforms? Is that your question? And yes, yeah, so asking about Q factors and things like that. So a very simple question, and we're going to send that to...
Yeah, the platform is totally different because the EnVista Aspire has a C-loop haptics and the LuxLife has those, we say, Mickey Mouse ears a little bit, but they all centrate very well, and also decentration and tilt and rotation with toric versions are excellent with both platforms.
Yeah,
Do you agree?
there is not a lot to add.
So what is the difference in the spherical aberration on the center of those two different platforms, which would depend on which of each we're talking about, the EnVista and the Lux platforms?
So the EnVista Aspire has 1.5 millimeters and is modulating the spherical aberrations, and I'm not a physician, so maybe you can ask about Lomb. People in the LuxLife, I think, had a more central part.
Yeah, the manipulation of the central part with the LuxLife is more pronounced than with the extended depth of focus IOLs, not only the EnVista, but all of them. It goes to the 4th and 6th range of spherical aberration, and it implies a positive and spherical negative aberration as well. Because otherwise, just modifying, just playing with either negative or positive spherical aberration would not give that wide range.
Yeah, they're complex optics, both of them, and not exactly equivalent in how they manipulate spherical aberration and higher order aberrations to result in that extended range of vision. Yeah, exactly what you said. Any other questions? Yes, in the middle. The question is for Elios, and it's in looking at secondary pigmentary dispersion glaucoma, and what are your tips around that for making sure you have effective fenestration formation?
Yes, so there has been one of my populations that I believe could do well for Elios includes pigmentary and pseudosphiliation glaucoma. when we have a very pigmented trabecular meshwork, it may be difficult to understand where the trabeculum is. I've never had to, but if you struggle with it, you can inject, for example, Vision Blue, a coloring agent, and it will allow you to see the trabecular meshwork. Otherwise, you can remove some OVD from the anterior chamber, so that way you'll have less IOP and you'll have more venous reflux, and you'll see the Schlemm's canal, and that way you'll know you'll be there. Also, aim a little bit higher. Always there's a parallax effect. So you would, if you see the line here, imagine this is the Schlemm's canal, in which you will see it only because there's blood, and you would put the probe slightly anterior, not completely centered, but slightly anterior, so that your aim is good. No,
Yeah.
but it does. So this is not related to pigment. So this laser, the xenon chloride, will do an ablation extremely precise and independent to pigment. So you won't have that problem. You should not do it twice. And if you're if you're not sure, but after Elios, if you decrease slightly the IOP, you will see some blood reflex exactly from the center of every one of the 10 trabeculostomies, and this is considered as proof as it's working.
Yeah, and you are limited to 10 treatments with the Elios as well. So if you retreat a spot, you would be not able to put another spot, but because it is an excimer laser, it isn't affected by the pigment there. But a great question. We do have mics if anybody needs a mic, but because we're taking 2 more questions. Yeah. So the question is about targeting for LuxLife. Is it plano, first negative, first positive? How are you targeting your LuxLife, and is it bilateral?
Well, being very early in this learning curve, the target should be closest to plano as possible, but in case first hyperopic value. Okay, and I would not go into let's have the second eye slightly myopic or so, unless we have enough information.
And we have time for one more question. The last burning question in the audience. Maybe somebody up top? Anybody? Yeah, I do want to thank our panel for joining us today, and all of you for taking this time in your afternoon for joining us. This was a wonderful audience and a really amazing panel. We're very fortunate to have you all here.